Thanks, Emily. And thanks for inviting us to such an interesting day. I can already, think about collaborations that you flagged up at the beginning, I can already feel my brain whirring just from the last couple of talks, so thank you. I'm just going to set it in context first of all. So CAEDS is a clinical team in the Michael Russ Centre. Starting really in the 1970s, Chris Dare began to see outpatients with eating disorders rather than young people being taken straight into hospital. Treatments then began to evolve through the 1980s, and in the early 1990s, CAEDS was set up by Ivan, who is still working with us, and Chris Dare. Moving rapidly forward to 2018, we now have over 45 members of staff. We have outpatient treatment, and we have an intensive treatment program, so day patients. We have about 315 referrals to outpatients every year. Our outpatients use day patient as well, but on top of that use of day patient, we have about 30 annual referrals for young people outside of our boroughs. We provide the service to SLAM and Oxley's at the moment, but we also take national referrals for the day patient programme and for consultation and second opinions. So sitting in that context is the huge acknowledgement that what I'm talking about today spans from a time before I started with the team up until what we're hoping to do in the future, and reflects the work of a huge number of people over those decades, including Ivan and Mima in the top, who lead our service, and all of us who are in the service, and our adult colleagues along the bottom who we collaborate and work with. It's going to be a real whistle-stop tour of what we do, but essentially it kind of starts in terms of the presentation and in terms of the history with treatment development, so family therapy for anorexia, multi-family therapy for anorexia, multi-family therapy for bulimia, looking at how those function in RCTs, but also how they function in everyday clinical practice and what the kind of long-term outcome is, moving quickly through how we should deliver them, what's the best place for those therapies to be delivered, and what are the cost implications of those different deliveries, then through to how do you then, as a specialist service, disseminate that to clinicians working nationally, and then bringing us back into the kind of detail of we've got these treatments, we've disseminated them, we know people do well, but not everyone does well, so how do we then fine-tune? And that's when we come to biology and personalisation. Our research really falls into two broad themes. So the first is thinking about how do you make sure that as many people as possible are able to access an appropriate and effective treatment nationally, not just within our service. And then thinking, actually, we've got these therapies, how do they really work? And how can we use the eating disorder neurobiology to enhance and adapt therapies to be as effective as possible? So tweaking for those who don't do well. Multi-family therapy for anorexia and family therapy for anorexia have been shown to be good in RCTs, and it's been shown in long-term follow-up that those who respond well to family therapy for anorexia stay well. So in adolescents, if they do well at the beginning, they're most likely to still be doing well 5 years later. So that led to the inclusion of family therapy for anorexia as the first-line treatment in the most recent update of the NICE Eating Disorders Guidance from 2017 for children and adolescents. Subsequent to the work on treatment development, the team looked at whether it makes a difference where you receive treatment for an eating disorder. And what they found within London was that if you received assessment and treatment in a specialist rather than a generic service, there's a significantly lower rate of admission for inpatient treatment and much more consistency of care in terms of what you're going to get. So thinking about the impact of our work, again, on national delivery, that then contributed to the development of the specialist eating disorder standard for children and adolescents, funded by £30 million from NHS England, and leading to the setting up of specialist eating disorder teams around the country. So now, wherever you are in the UK, there should be a team near you that can deliver specialist treatment rather than have to either travel all the way to London or sit in generic CAMHS where we know you're more likely to end up needing an inpatient admission. Linked to the London study, the cost of treatment was looked at because, of course, your immediate thought might be that specialist care is more expensive. But what the London study showed was that the costs are lower if you're assessed and treated in specialist than if you're assessed and in non-specialist and then moved into specialist, or you have everything in non-specialist. And what really drives that effect is the reduction in inpatient costs if people come into specialist care. But if you look at the difference in outpatient costs, that still doesn't really vary between specialists and non-specialists. So it's not that you have a more expensive outpatient but you reduce inpatient, it's that you reduce inpatient and outpatient is much the same cost. That's been expanded into an examination of across the UK, looking at health economics in specialists and non-specialists. It hasn't reported yet, but it does look like there's going to be some cost benefit to specialist services. Our future plan, with an application that we're writing at the moment, is to look at what the cost implications are now that these specialist services have gone nationwide. Are we still seeing the same clinical and cost benefits that we've seen in London? Okay. As well as RCTs, we're also interested in how therapies work in everyday standard practice. Much like Bruce was talking about with OCD, we see a lot of people, we collect a lot of data. So doing a recent audit, we have nearly 300 people, 98% of those with a restrictive eating disorder have family therapy, about a third of them get multifamily therapy on top, but about a third of them still need day or inpatient treatment on top of family therapy. And those are the young people who end up being in treatment for longer. They're lower weight, they have more cognitive symptoms, they're lower mood, they're more anxious. But when we look at a regression analysis in terms of trying to work out who does need more, the only thing that really contributes to that need for treatment enhancement is weight. The problem is that that doesn't really contribute very well. It doesn't really predict who's really going to need extra treatment. So we can't say that our lower weight young people coming in are the ones that are going to need more and therefore tailor their treatment from the beginning. So we're still left with this question, how do we predict who's going to need more later on, and how do we therefore kind of serve them better earlier in treatment? We're currently trying to get ethics to contact that audit sample, but they've all been discharged from our care now, so it's a little tricky. But we're also using CRIS to look at their pathways into adult services. So we're interested in, is it the same as in RCTs where those that do well with us stay well, or do we see a kind of later drop back into adult services? But also, what happens to those that don't do well? Where do they end up in the adult world? Importantly, we know that a significant proportion of young people don't have a good outcome from RCTs or in everyday clinical practice. Even in a specialist team, we've got 25% of them at the end of treatment that aren't doing very well. So we want to know, how can we improve that? And there's lots of ways that we're looking at that. I'm going to flag up posters for you to go and have a look at, because we've got quite a few. One thing we're looking at is over-control personality traits. Does somebody's rigidity and social withdrawal lead to a kind of chronicity of need, a chronicity of disorder, and can we address that in CAMHS before it goes into a chronic adult picture? There's a poster looking at how we're just trying to capture a measure at the moment to capture that in adolescence. It's not something that's been looked at before, and we've done a pilot of treatment in CAMHS. We're looking at whether attachment-based family therapy can help young people where there's been a rupture within the family. Can we fix that rupture in order for them to benefit from our family therapy treatment? Family therapy for anorexia really requires the involvement of the family. It's not about fixing the family, it's about using the family to recover. So if you have a rupture, you know, that's not naturally going to work so well, so can we fix that? We also have Tom Jewell in our team, who's doing an NIHR-funded PhD looking at whether attachment and mentalisation can help us predict who's going to do well in family therapy. And we're also looking at treating common comorbidities within the context of anorexia. So thinking about what Bruce was saying earlier about how the low-weight young people in the OCD service didn't do so well with CBT for OCD, gives us a big question. We've got a lot of low-weight young people with anorexia and CBT and OCD. Can we treat them? So there's a poster talking about Jonathan's case series looking at CBT for OCD. But we're also really interested in the neurobiology, and our collaborations with the adult eating disorder clinicians and researchers are really helping us to think about this. We're really wanting to develop CAEDS involvement with that and expand our research into that area. We really want to think about how the neurobiology and neuropsychological features of eating disorders can help us really think about what the treatment targets are and think about treatment development in that light. So I'm just going to give you a few examples of how that's happening. So we're collaborating with Kate Chanchuria to look at the impact of autistic traits on the progress of anorexia in young women, particularly in terms of recovery. And we're scanning cognitive and emotional, we're getting young people to do cognitive and emotional tasks in a scanner. And then we're looking at whether there are links between their responses to that and their recovery 6 months later. We've seen that young people with autistic traits respond well to our treatment in terms of their weight gain and their physical well-being. We can get them physically better, but they have attenuated change in the cognitive symptoms of eating disorders. So what we wonder is whether that attenuated change there leads to a risk for chronicity as they move into adulthood. We know that in the adult eating disorder population there's a far higher level of ASD than you would expect from the general population. There's a poster on that as well. Okay. We've also collaborated with Jessica and Ulrika looking at attentional biases. There's research previously showing that people with anorexia may have learnt to selectively look away from food. And that kind of perpetuates the difficulties. So we looked with a visual pro paradigm at attention allocation to food stimuli. And interestingly, what was found was that whilst adults with anorexia show significant avoidance of food stimuli, adolescents with anorexia don't in comparison to their controls. They don't already have this selective bias. Now, this is important because it highlights the need for early intervention in eating disorders before these processes have got caught up into the kind of attentional bias, which is keeping it stuck. Getting in early matters. But it also, importantly, indicates that attention bias training for food cues is not indicated for adolescent AN. It's not an area that this suggests we should be pursuing. Okay. Going to move us into bulimia. Bulimia is interesting because we have much poorer outcomes in bulimia than we do in anorexia. The abstinence from binge purging is only about 25 to 45%, even in RCTs. And our service audit shows that only about half of our young people are discharged with no bulimic symptoms. We've tried to develop therapy to address some of that and to try and get a little bit more traction with it. But we have a real dilemma because people tend to delay help seeking with bulimia. We have low service use in CAMHS, and that's a real barrier to research just because we do not get the numbers coming through. It's a disorder filled with shame and guilt and is hidden, and teenagers are not coming forward saying, help me, and their parents are not pushing them forward like they might with the fear of anorexia. Theoretically, we think we might be treating bulimia rather than treating different subgroups with appropriately tailored therapies, but we can't do much to investigate that without the numbers coming through that allow us to kind of split people off and work out what those groups might be. So we address this by working with BEAT and working on some online focus groups to find out from people who have bulimia and are teenagers now and who are in their early 20s and can look back and find out from them why are people not coming forward and how can we help? And the key message from all the groups was get out there and let people know. Young people didn't know that they could get treatment for the symptoms they were experiencing. They didn't know it was a mental health condition. A lot of them were having treatment for depression, anxiety, self-harm, but no one was asking them whether they were binge purging, and they weren't telling, A, because they didn't know it was relevant, and B, because it's so embarrassing. So BEAT said to us, get out there. The young people said, let people know. So we got a Guy's and St Thomas's Health Innovation Fund grant and developed an outreach approach. We've been out in schools, youth groups, churches, telling people that we're here and telling people about bulimia. We've spoken to about 10,000 young people in assemblies in less than a year to let them know, and our referrals have increased. There's a poster on that as well. It's in the demonstration room. So for the future, we really want to use this boost in referrals to be able to do the kind of standard of work with bulimia that has been done with anorexia. We want to keep those high numbers coming through, which means we need to keep being out in the community, and we want to think about these neuropsychological profiles and clinical profiles and think about how we can tailor treatment appropriately. I've got less than a minute, so just very briefly to say we've also been out in schools thinking about universal programs around body satisfaction. This is a program from Australia, but we've been interested in two things. One is, does it have the same impact when it's us, not the developers running it? But secondly, and importantly, can it be run as effectively by school staff as it can by clinicians? Because there's only so many of us, and there are tens of thousands of young people out there, and if we have a program that can be run by people on the ground, our reach is much higher, which links back to the beginning, thinking actually it's not just about doing something effective, it's about doing something effective and then allowing other people to do that as well and really spread the impact to as many people as possible. We've got early thoughts about primary school level programs as well, but I think I'm probably out of time. So just to say, we're a clinical team, but we're founded on research and evidence. We really think about the academic development of clinicians. We've led the national development, and what we really want to think about is how to improve outcomes for those that don't do so well with our current treatments.